This is actually quite a low-tech presentation, and I need you to change gear and try and stand in the shoes of the clinicians who are ordering pathology tests and think about the kinds of information that they would want. So I work really in the Ministry of Health in New South Wales, which provides services for New South Wales. And in that organisation there are two groups, one looking at quality and safety, which is the care of the Clinical Excellence Commission. And the second group is the e-health group, who are responsible for implementing clinical systems across the state in New South Wales. So today my talk is just going to take you through the journey of how we started to think about clinical analytics and try to get it on the agenda for the state, because their focus was not on clinical analytics, it was on implementing clinical systems. And I'll take you through two examples of where we took some really simple information and played it back to the clinicians at two projects. And then I'll finish up by explaining how, using those kind of case studies, we help to build the momentum around thinking that we need to actually put some resources and funding and a strategy into how we really help clinicians with information as we go forward. So one of the key things that we thought about, it was about 2 years ago, we were looking at the quality and safety requirements and how little information there was to actually play back on how the state was performing with various quality and safety pieces of information. And so we decided that the evidence coming back from overseas was that big data was playing a part in actually improving healthcare, that systems that had been implemented for quite some time were now able to be accessed and really look at the information and use that information to sustain good quality improvements in healthcare. And it was something that wasn't on our agenda from a New South Wales health perspective. Another motivating factor was that within the Clinical Excellence Commission there was a program underway looking at the impact of diagnostic test management and the various aspects of that practice that were causing problems in the care of patients in New South Wales. Looking at things like appropriate ordering of tests, and missing results, and the results not being endorsed properly, and looking at the various practices around diagnostic test management. And I was invited to join that group, and it was clear that they really didn't have data to work with. They were working on feedback from people's opinions rather than on a factual basis. And the last piece really where we started 2 years ago was that we understood that the implementation of clinical systems was the priority. But in doing those implementations, there was absolutely no emphasis on the information that you could get out of those implementations. It was a focus on get the systems in as quickly as possible. And of course, we're only about 30% of the journey towards implementing proper digital healthcare. There's still 70% more implementation to happen. And that's where all the energy is. But very little energy is going into sitting down with the clinicians and asking them, well, what do you want back from what you've put into the system? So that was my focus. To set the picture, I found this nice diagram, which is the usual iceberg diagram, showing that there's a lot in there and you can only see the top part of it. And I was just explaining to the audience that there is a lot of data in there, not much information. But yet, if you tap into it, you can actually turn that into something quite useful. The other thing that struck me about this image was that when you look at the iceberg, it's just totally irregular. It's like a rough diamond. And I thought that actually symbolized some of the symptoms that we have when we look at what has been implemented, because there's no standards. and there was no thinking when we put it in about the questions that we would want to have answered. So I think the iceberg does a good job there, just showing how rough, incomplete, and imperfect the kind of picture is that we're starting from. I use this next diagram to engage with the various stakeholders about where clinical analytics from our perspective sits in the overall strategy of implementing systems. And you can see at the bottom layer, it's dependent upon really good standards being in place. It's dependent upon systems being able to talk to each other. And when you've got a foundation of that happening, and when you have technology in place that's not hindering clinicians, but actually easy to use, you move up to that middle band where you start to get some more refined views of the information that's been put in. And then finally at the top layer, through analytics, we start to have the capability to measure the outcomes, which in turn will provide us with the intelligence to actually sustain improvement in healthcare. So that was just our little story about why we're doing this and where we're at. And of course there are major data warehouse projects underway, but we had to kind of create and make space for this new debate about new information and high volumes of new information, as I've heard it described as the tsunami of new information coming through. We're not in any way ready to store it, examine it, display it, and make use out of it. So we're thumping at the table and saying, listen, we've got to do something different here. We've got to get a different focus. So I work on my own, and I was given the opportunity to go off and try 3 little projects. One of them is around the diagnostic orders, which we'll look at today, but there's other analysis that we're doing to try and give back value out of what has been put in. An example is just analysing what's happened to patients when they've had a rapid response call and feeding that kind of practice information back to clinicians. And the other one, which I'm really keen on as well, is we have tools that lets us understand the experience of clinicians in interacting with the electronic medical record, so that you could actually go in and refine it and tune it and improve it, which is very important for their engagement as we progress with our implementation. Key from our thinking was that it's really about engaging clinicians with information rather than saying this is what you can get and this is what we can deliver to you. It's about them wanting to have that information and about using that information to bring about practice. So we wanted to learn how best to do that as part of our strategy. And we wanted to be able to demonstrate that if you do that, they will bring about change. And then lastly, we wanted to find some really simple tools that they could use. So the first project was at Coffs Harbour Hospital in New South Wales. Got to meet with the Director of Medical Services, a mid-career clinician who was passionate about information, really busy lifestyle, very challenging circumstances, but really understood that good information would help him drive better outcomes for the patients and for the hospital. So we agreed that we would look at an analysis of the orders placed by the various clinicians in the hospital over a 6-month period, and I created these dashboards based upon that information, and we had several kind of discussions and changes to the views that were created. Each discussion building upon answering the questions from the previous session, and I'll just take you through some of the views that we created. So to do that, I needed to find a simple free tool because there was no money for this, and so there's a little add-on to Excel called Power Pivot, which fit the purpose very well. It just allows you to drill down from a high level down to the individual test or person who placed the test. In terms of the data items that we looked at, it's just an array of about 40 different pieces of information that we extracted from the electronic system. It was centered around the details of the patient and who placed the order, the details of the order itself, and also looked at the results that were conveyed about the test, which was also part of our discussion. Once we pulled out the data, as always, you need to transform it and change it and add pieces on. So there was extra things like the time of the day of discharge and so on that were necessary to make the information more meaningful. Here's the array of about 14 different discussion points that I had with the Director of Medical Services. These were questions that he had about ordering practices that we had to create information for. And I'll take you through just some examples and why he wants to know the answers to those questions. So the first view is what he called the headlines view. It was just give me 4 quick snapshots of what's happening. So the first graph is just a simple trend over time of the numbers of orders placed for the organization. The second one on the right-hand side, he was really interested to know the time of the day that the orders were being placed, and also what was happening around Fridays and Saturdays to see if there's any practice issues that we could address with that kind of information. And down on the right-hand side, he wanted to be able to see the turnaround times for specific orders so that he could understand what was holding up the processing of patients. And then the last pie chart there is the status of the various orders. And the way that the dashboard works, down the left-hand side, you can see various filters. So you can go in by a specific test, or go in by look at it from a pathology or a medical imaging perspective. And we created a little thing called focus orders, so that rather than having a look at all 5,000 types of orders, you can just pick, say, the top 10 that you want to examine in detail. And when you pick a particular order, well then obviously all those graphs change so that you can see in detail what happened there. So that was something that would give him a straight up picture of how things were on a monthly basis. The next set of discussions that we had was around, he said, well, we do business by teams. We have teams of junior doctors with senior doctors, and that's how we work. And the real challenge we had was that that team would change every 6 weeks or whatever. And the maintenance to actually move that group of people from one team to another team, we actually don't have the technology to do that, and it just wasn't something that we could solve. So the closest that we could get was to do the analysis by specialty. But I think that was a message that we learned anyway, was that our technology hasn't been set up to do a very simple handover from one group to another. The next set of questions was fairly straightforward. It's really, tell me about the patients who had all these tests. What were they? Let me know by diagnosis. And in the table there, you can drill down so you can see specifically by doctor, by diagnosis, what tests have been ordered. So that was something that he was really interested in, and he was quite amazed at the volumes of tests that were being placed for some of the patients. The next discussion we had was around order sets, and order sets are where you group a set of orders together based upon a condition, because from a best practice perspective, this is what you should be doing, but also from a workflow perspective, it makes it really fast. If you have these 5 tests, you can place them very quickly. So this view here just fed back to him the fact that only 10% of the orders that were being placed in an order set. So 90% of your ordering is just ad hoc, random, and so on. So that was very useful to understand how they needed to promote greater use of order sets. And then in looking at how you bring about that change, we needed to know, well, who are the high users and who are the people who don't use it at all. So this particular view allowed them to see who needed to talk to promote the use of order sets. Another discussion, there was concern that nursing were placing orders that they really shouldn't have been placing. And again, looking at the data, we could see what particular orders were being placed by nurses. You can drill down behind each of these categories to see what orders were being placed. Also, pathology were complaining about a high level of cancelled orders, particularly around the January-February timeframe when new staff came in. And we're able to see, come to the conclusion that the education for staff coming in needed to be improved to help them understand the way the orders have been set up in the catalogue. So this feedback here around who was cancelling orders and when was useful to actually identify that our training needed to be improved. Next one is pretty simple. It's around the frequency of orders being placed. However, my ability to actually do a good dashboard was limited here. I'd much prefer to have a little slider where you could change the specificity, the time duration a bit better. But at least it uncovered some unnecessary duplicates that were coming through. Orders on the day of discharge was of interest as well, because why would we order something that's going to take 2 days to come back in a result? And if it did come back, did it even get into the discharge summary? So we wanted to have a conversation about what's appropriate on the day of discharge and why was it happening. Patients who went home without the orders actually being signed, again, it's just a quality practice issue that they had no idea that this was going on, and this was something that they could have a look at. And then finally, from their perspective, these are the orders that were placed, and the patient has gone home and the result hasn't come back. So it just gave them some insights into their workflow around the time of patients going home. I continued to work with Dr. Alvarez for a couple of months on this data. Unfortunately, he moved on to another local health district, and we lost momentum with that. He had several more questions in his mind that he wanted to have answered, but the exercise, at least gave us an idea that there's real interest and there's real value in being able to do that analysis. Down the road, there was a second project started in Port Macquarie Hospital where they were very specific. We went through the same extract, but in this particular case, they selected one test. They said that C-reactive protein was just way overused. So Dr. Travanik down there engaged in good change management practices. He engaged with the junior doctors. He went through the literature review as to why you shouldn't be, you have to be more appropriate in your ordering of that test. Got the support of the senior clinicians and, entered into dialogue with everybody about why should we do this and is this the right thing for the patient. So his approach and tactics were excellent. And he supported that then by just feeding back to them the data so that they could see the progress that they were making. And over time, you can see that the numbers of tests ordered have dropped dramatically and have stayed that way since we implemented it. And based upon that success, then he started to pick off other orders and watch the trends as things had happened. The important thing is they were starting to look at the data. And because they did that, then they could spot other things. And down at the very bottom, you probably can't read it, but venous blood gas, you can see is going into the red there. And that's simply because they put an analyzer in the ED department and it's getting worse. So, only that they were looking at it, they probably would never have known that that was happening. So the summary from the Port Macquarie experience was that using good change management and feeding back and collaborating with the junior doctors, you can actually, definitely sustain the improvement. So based upon those two projects, here's the summary findings that we discovered from that. First of all, that If we were to really work with clinicians on the ground and support them with the information, we absolutely don't have the resources to do that kind of work. Because what I had to do was go and have a discussion, change the data, have another set of discussion. It was completely iterative. And to keep their interests up, it really needs a dedicated person on the ground doing that change the whole time. And in the way that we're set up, we don't have the resources, but we actually really do need to invest in that area to make this thing work. Second thing was, when you looked at the ordering practices, we were looking at the implementation of electronic orders that was put in, say, 8 years ago. And nobody had really gone to think about the rules that we put in at that time. We put in some really static rules which caused, if you like, alert fatigue. Nobody even looked at it anymore. There was duplicate alerts going in for everything, and it just didn't mean anything. So that certainly came to the front. We understood then from feedback from the clinicians that our decision support that's there, and I'm just speaking from the systems that we're looking at, just really didn't give them useful information if that's what we're trying to do. They are, concerned about cost, but there's nothing that we can tell them about what they're actually doing. And we're not telling them about the alternatives. And then in terms of the system itself being optimized, they were interested in kind of problem-based ordering and looking at different ways of doing things. And there were also, we really didn't have a good way of tracking down whether the orders that they've been placed have been acknowledged and resulted properly, okay? We had no idea. We were sure that they looked at the results, but there was nothing in the system to tell us that that was a positive confirmation that that was happening. And then the final 2 points there is that, look, if you do engage and you work with them, it's definitely the way to sustain the improvement going forward. And whatever you give or whatever tools you create, it has to be self-service so that they can go in and ask the questions for themselves and get the answers very quickly, or else you need to have somebody doing that for them and providing the answers. So based upon all of that work, we set about organising a statewide workshop with pathology and imaging. More than 100 different people turned up to have a discussion about what your priorities are, what do we need to look at in terms of appropriate ordering, and what kinds of things would you want to see in the systems that we're creating for tomorrow. So that was really useful. The kind of dashboards that we created and those discussion points have been shared with a number of the LHDs so that when they're building their own systems, they can put those sets of questions in there. And we've created the training tools so that anybody who wanted to reuse some of the work that we did, they could. And certainly the recent Choosing Wisely initiative has actually kept this topic on the agenda, so there's still an ongoing interest. And looking a bit beyond the horizon, certainly the outputs from the project has helped us promote clinical analytics. The doctors that we worked with, we've brought them in to form a clinical analytics task force to be the advocates for creating the space to invest in this area. There is an analytics strategy being developed by New South Wales Health to properly address things, but it's still quite slow moving, and the kinds of things that we want to do need to be a bit more proactive. And the final thing is that even if we don't have the tools to build in, we have the realization that whatever systems we're interacting with, we've got to build into place the data collection points and the metrics that would help us do the analysis later on. So when I think back to that iceberg picture that we started with, with all of its jagged edges, I think what we're moving towards now is just a more solid cube of ice that's floating very much higher in the water, because we now know that we need to take more out of what we've put in. So thank you for your attention. I'm looking forward to the rest of the day because I'm going to learn an awful lot about the technology of pathology and see how we can implement that in our systems. Thank you.